I'm Doug Johnston. I'm the Chief of Cardiac Surgery here at Northwestern Medicine and Bluhm Cardiovascular Institute. And with me today is Dr. Kevin Hodges, head of our robotic and minimally invasive surgery program. And we're here to talk about the robotic maze procedure. So Kevin, welcome. Maybe you can take us through a recent case that you've done, a robotic maze, and tell us what makes this different from standard arrhythmia surgery and a little bit about the team that's involved in getting these cases done.
Most of our patients that come for a robotic maze procedure have a similar story. They have multiple previous ablations, maybe in an EP lab. They failed that, they're dependent on antiarrhythmic medications, and they're all taking blood thinners, and most are unhappy with that lifestyle. They come to us for robotic maze because the biatrial maze procedure is the best arrhythmia surgery that there is. The problem is historically it's required open heart surgery and a median sternotomy, and this allows us to do the same complete biatrial maze procedure through a minimally invasive approach using robotic assistance.
So you do a lot of robotic valve surgery. How does a maze compare to a robotic mitral valve repair?
Well, I think that's what's so great about this. This is a relatively novel procedure, but it's the exact same approach as a robotic mitral valve repair.
When you talk to patients, what do you tell them about the advantages of a robotic approach?
Yes, the recovery is about 2 to 3 weeks with minimal activity restrictions, and people can really get back to their life with minimal interruption.
If you're a cardiologist who has a patient with difficult AFib, what would you like them to know about the robotic maze program and about the option of having this operation available to their patients?
This is really the equivalent of a standard biatrial maze procedure that we often do concomitantly with valve surgery, which is really sort of the highest tier surgical ablation procedure that's available. This is a complete biatrial lesion set that gives patients the very, very best chance of eliminating their atrial fibrillation.
If you don't mind, say a couple of words about what makes this different from a TT maze or transthoracic maze and the convergent procedure, which other people may be familiar with as hybrid options.
That's a great question. So both of those procedures are off-pump procedures. They're entirely epicardial lesion sets that allow a partial version of what would otherwise be considered a maze procedure. So with just epicardial ablation, we can't do a full lesion set, which is why we rely in part on electrophysiologists to do a second stage transcatheter ablation procedure. In either case, it never quite matches the complete biatrial maze lesion set. This is an on-pump endocardial cryoablation that allows us to get all of those lesions.
So I and our audience understand the nuances here. This is not only a standard maze procedure, but you're ligating the atrial appendage as we would with any other surgical ablation procedure.
Exactly, and I think that's actually something that differentiates what we're doing at Northwestern from other people that have discussed doing this procedure with a robotic approach, is that we actually do a left-sided thoracoscopic application of a left atrial appendage clip. This topic's been studied extensively, and epicardial placement of a clip across the left atrial appendage is the most reliable long-term management of the left atrial appendage. And we want to make sure that if a patient comes to us for a robotic maze, that the left atrial appendage is managed definitively.
Well, thanks very much, Dr. Hodges, for joining us. This is a very exciting addition to our robotic cardiac surgery program, and I'm hopeful this will expand really high-end AFib therapy to a much larger number of patients.
Thank you.